Okay, everybody, we're going to get started with our last session. We saved the best for last, and we had a little pinch hit here, a little change in the order. So we're going to do a state-of-the-art talk first, and then go into the abstracts. And for the state-of-the-art, we have really an international thought leader in Barrett's esophagus to speak with us, and a familiar figure to everybody with the Southern California Society for Gastroenterology. Raman Muthusamy is the medical director of endoscopy at UCLA, and he is the, let me get this right, Leon J. Tiber and David S. Alpert Chair in Medicine at UCLA. And Raman, it's a pleasure to have you as always.
Okay, well, good afternoon for the home stretch here. Thank you, Gareth and Eric and Kikin, for the opportunity to be here today. So I'm going to talk to you today about state-of-the-art in management of Barrett's from detection to treatment. So these are my disclosures. So Barrett's is an interesting disease. In medicine, we've got many diseases that we can effectively diagnose, but lament the fact that we don't have any good treatments for them. But in Barrett's, I would argue it's the exact opposite. We have developed excellent and durable treatments over the past 20 years that we can basically get rid of Barrett's in just about anybody we want. The problem is we can't find the patients who have the condition. Furthermore, even in those that we do find that have the condition and place in surveillance, there's a lot of challenges we have in detecting dysplasia, and even more in predicting which patients with non-dysplastic Barrett's are going to progress to dysplasia while under surveillance. And finally, many patients we have under surveillance perhaps are incorrectly diagnosed with the disease, leading to variability in risk estimates for progression. So how do we do better? In my talk today, I'm going to talk about detecting patients with Barrett's. How do we detect prevalent dysplasia in patients in surveillance? How do we predict future progression to dysplasia? And then a brief update on eradication therapy for Barrett's, with some conclusions. So who should be screened for Barrett's? We know Barrett's is probably present in 1 to 2% of the US population at least. That's about 6 million people. And 6 to 18% of GERD patients will likely have Barrett's. But we know that many patients with GERD have atypical or even sort of no true heartburn type symptoms. Barrett's esophagus is also often found in asymptomatic individuals between 6 and 25%. And about 20 to 50% of patients with esophageal cancer have no antecedent history of GERD symptoms, and less than 10% of adenocarcinoma patients had a known prior diagnosis of Barrett's. So the problem is that most of these people are walking around and they show up with their T3N1 cancer when they have dysphagia, because we haven't been able to find them. So should all GERD patients be screened? Only some? If so, which ones? And should GERD even be a prerequisite in order to screen for patients? So what are the risk factors for having Barrett's? Well, we know if you're over 50, if you're male, and if you're Caucasian, those are risk factors. You can see the odds ratio is 1.5 to 2. Yes, chronic reflux is a risk factor. You can see the odds ratio of 2 to 3 if it's weekly or 5 years. It's up to 30 if you have early onset, less than age 30. Central obesity, smoking certainly also play roles. And then again, family history, while uncommon, is actually a big risk factor, 12.3 for an odds ratio. And it turns out that the risk of Barrett's increases by about 1.2% for every one of those risk factors. So the more, the better. So there are some tools that have been out there that have been developed to figure out who might actually have Barrett's. This is one from Joel Rubenstein at the University of Michigan, looking at weekly GERD or not, whether you have age by 10-year increments, waist to hip ratio, pack years of tobacco use, and you can see the red line, the area under the curve here, is better than just using reflux, which is the blue line. In fact, just about every model beats reflux. You can see there's 5 models on this list. The green line is reflux, and that's at the bottom, and you want to be on the top left here. So essentially, numerous models exist. And the fact is, we don't really know the optimal number of risk factors that should trigger perhaps a screening. Models utilizing readily available information from our EHRs that might automatically alert our PCPs to refer patients to us for screening are beneficial. Hashim El-Sarrag at Baylor has actually published on this. And we need a validation among a more diverse population. A lot of these are in subsets of perhaps VA patients, but we probably need it in populations that include more women and minorities. So this is how we find patients we might want to screen, but the next question is, how do we screen them? Do we do standard endoscopy? What about unsedated transnasal endoscopy? tethered cell collection devices, maybe something else like blood, saliva, or even volatile organic compounds. So there's a lot of advantages to using a minimally invasive screening tool because, of course, our rates of detection of Barrett's are directly proportional to how good a test is in finding it, sensitivity, as well as the participation of patients in the sort of program, as well as their access to that program, right? So they have to be willing to do it and they have to be able to do it. So some of these non-endoscopic options or unsedated options might allow greater participation, improve access, perhaps may allow for non-physician administration and lower costs. So what about transnasal endoscopy? Well, the studies in those who have willing to undergo it show that it's accurate, sensitivity and specificity above 90%. It's actually well tolerated and safe. Those, again, who have actually done it have said that it's got a comparable patient preference to sedated endoscopy. It's less expensive and it potentially could be done by non-physicians, but for whatever reason, from a perception standpoint, at least in most Western countries, it has not gained traction. This is a study that, there we go. This is a randomized trial by Prasad Iyer at the Mayo Clinic, where he basically took 3 groups. One group on the right is the sedated endoscopy. The one on the left is a hospital unsedated transnasal endoscopy, and the one in the middle is the most interesting. It's a mobile unit. They basically drove around Rochester, Minnesota with a little truck like an ice cream person, and they basically said, you want to hop in the back and get scoped? And they did, 48%. They had the highest participation, actually. So, and you can see that I told you 1 to 2%, but in Olmsted County, it was 8.5% Barrett's rate, 30% had esophagitis. So again, bringing it to the people, okay? And this is an interesting approach. So it can work if, again, patients, if it's accessible enough. So what about cell collection devices? So there's Cytosponge, EsophaCap, EsoCheck. These are all devices that essentially you swallow. It's office-based. It takes about 10 minutes. I've had this done myself. And you just swallow this pill on a string. You wait 7 minutes for the capsule to dissolve. You pull it out. You feel a little bit of heat when it comes out, but it's not bad. 99% feasible in the UK, 3% were diagnosed with Barrett's there, and it works better for a little bit longer segments. So you can see the sensitivity specificity improved for 2 centimeters or more compared to 1. This is a big trial that was actually published in The Lancet by Rebecca Fitzgerald, who developed the Cytosponge device. 13,000 plus patients, half of whom got Cytosponge and half of them got usual care that, you know, if they had reflux and they had to meet certain criteria, they could get an endoscopy. And they increased the diagnosis of Barrett's in the group that got the Cytosponge by 10-fold because it was just easier to administer and it would trigger more endoscopies. So you can see the rate ratio of 10%. Now, this may be a little small to see here, but again, these are kind of a summary from the American Journal of Gastro, from the ACG's most recent Barrett's guideline. So it basically defined Barrett's as having at least 2 centimeters in length. Of course, we know the minimum terminology is 1 centimeter. But you can see Cytosponge on the top, performance characteristics, sensitivity 75, 80%. And you can see the methylated DNA marker ones, which are the other techniques I showed you, with even more improved performance characteristics in the 90% range. So currently, both the ACG guidelines and the most recent AGA clinical practice update, both from 22, both recommended that these are options to an endoscopy to diagnose Barrett's. Now, in terms of guidelines for screening, pretty much every society, for the most part, has said multiple risk factors, typically with GERD as a prerequisite. I will comment that the most recent AGA clinical practice update in 22 actually said you just need 3 or more risk factors. GERD was not a prerequisite because so many patients don't actually have symptomatic GERD. They have silent GERD. So it's one of many, but it's not the prerequisite. So that's a little bit about how we find these patients that we're missing. But in addition, we want to characterize these patients appropriately and not mischaracterize those who don't have the disease. So we need to kind of remember the anatomy. So the current definition of Barrett's esophagus, again, is that you have to have 1 centimeter of the tubular esophagus, which is the region above the gastric folds, both having this sort of salmon-colored appearance, which you can see with the circle there. But then you have to biopsy that area, and you have to histologically see evidence of intestinal metaplasia, which is sort of identified by those goblet cells, the sort of the big purple cells there. The 3 essential steps for endoscopic diagnosis and treatment are both recognizing the squamocolumnar junction, identifying the gastroesophageal junction, knowing where the end of the gastric folds are, and then describing that length of columnar mucosa. So here's a couple of photos here, and again, there's the top of the fold, and then there's the top of the fold. Everything Downstream of that, or distal, is actually stomach. The region of Barrett's begins proximal to where those arrows are. So the three things that we always teach our fellows is, tell me where the diaphragmatic pinch is, which you can see there at the bottom. Tell me where the end of the sort of gastric folds are, which would be here. And then you want to describe the total length of the circumferential Barrett's and then the total metaplastic length, which allows you to get sort of the C and the M length, which is circumferential and metaplastic, which is this Prague criteria that's used to describe Barrett's. Again, a reminder that islands don't count according to that notification. So common mistakes, and I'm going to talk about this in the abstract section as well. There's been sort of the general mantra is you don't biopsy the Z line because that can lead to confusion, and that's not supposed to be associated with an increased risk. That may not be accurate, but we'll come back to that in a minute. And then, of course, the other thing is calling a length here where you can see gastric folds as part of a length of Barrett's when it's in fact the proximal stomach. So does this really happen? Yes, probably does. A community-based study found that about a third of patients who were diagnosed with Barrett's didn't actually meet the criteria that we just talked about anatomically. A VA study found that as much as 1 in 5 patients who were defined as having long segment Barrett's didn't actually have Barrett's, and a third, again, of short segment. So again, these are patients who are getting surveillance unnecessarily, worrying unnecessarily, and actually are never really going to develop sort of these esophageal cancer, and to falsely sort of lower sort of the rates of progression of patients who truly do have Barrett's. So switching now to detecting prevalent dysplasia. So these are sort of what we consider the 10 steps to a high quality examination. This is something we outlined in our clinical practice update. So we talked about getting the landmarks right. Using a distal attachment cap is very helpful. Cleaning the mucosa with a water jet and carefully suctioning the fluid to get the mucus off. Using carbon dioxide to use insufflate, desufflate can sometimes bring out subtle lesions, and spend adequate time inspecting. I'll get to that in a minute. You want to examine high definition white light, which most of you should have with your modern scopes, but you can also use virtual chromoendoscopy, things like narrowband imaging or link color imaging. You can also, again, use the Prague system, again, to sort of be accurate in your description of the Barrett's. If there's a visible lesion, you can use the Paris classification, which we often use for the colon, to also describe those lesions. And take the Seattle protocol biopsies, which is usually 4-quadrant every other centimeter in patients with non-dysplastic Barrett's. So how do you perform a high-quality exam? This hopefully will kick in. So again, you see a high-definition scope, you see a cap. Start with the diaphragmatic pinch. You sort of comment upon that. You pull back. You see where the end of the gastric folds are, which is down here. And then now you're into this tubular esophagus. You're sort of looking, you kind of center, take your time. You can even sort of, similar to colonoscopy, kind of do a smile. Here you've got obviously a pretty obvious posterior wall lesion here, which is several centimeters. That's going to require, resection or ESD. And certainly biopsy that separately, and then go back in the stomach again and do the same thing, this time with narrow band imaging. And I'm going to come back and talk with you a little bit about NBI in a moment. So you can see the same lesion. So this is generally how we perform a good exam. So one issue is time. So this study looked at patients who had an inspection time of less than 5 minutes versus more than 5 minutes. And you can see that they doubled the number of visible lesions, more than doubled the diagnosis of high-grade or cancer. And these were all in patients who had similar Barrett's lengths. And they suggested using a 1 minute per centimeter of Barrett's for withdrawal time. You can use acetic acid, vinegar. You can actually just spray this at a 1.5 to 3% solution. It really helps enhance the mucosal pattern, as you can see there. And high definition white light can help determine aberrancies that you can target. And using the American Society of Gastroenteroscopy PD thresholds, which are felt to be a sort of minimum criteria to use a technology or technique, this is the only chromoendoscopy technique that met those criteria. Narrowband imaging. So this is something that is push button technology that most of you have on your scopes. It uses blue and green light to highlight surface vessels and subepithelial vessels. The surface vessels will typically be brown, as you can see on the top right. The subsurface vessels will look a little green. And the goal is to characterize, differentiate, and diagnose based on the imaging characteristics. This is a group, this Barrett's inspection neoplasia group that met, and they basically tried to come up with criteria, and they kept it simple. They said, look at the mucosa, is it regular or irregular? Look at the blood vessels, are they irregular or irregular? And then using that information, you can predict whether there's a dysplasia or not. So here's a group of normals. You can sort of take a look here. The glandular pattern is normal. You see there's a great deal of regularity here. And then here, when you sort of look, you can see some increase or change in the vascular pattern. You can see some of these glands look a little bit different. I always tell the fellows, it's like when you're on an airplane looking down at a housing subdivision, it looks nice and orderly. And so if it looks like that, then it's good. And if it looks like the roads are all jacked up, then you're probably dealing with dysplasia and you should target that. So it turns out that this is a simple system, but it's pretty good. And when the doctors said that they had high confidence, they were accurate for finding dysplasia about 92% of the time. And they knew when they weren't so confident because their sensitivity dropped to 62% on the low confidence. So this is something that potentially could be taught. Now, what are other ways that we can teach? This is a web-based video platform, the Born project out of the Netherlands, where they ask physicians to look at a video, say, tell us where's the lesion, where would you biopsy, demarcate the lesion, okay, so you had to figure out where it is. Then they reviewed outcomes, and then they had them sort of take tests again. So they had them do a whole bunch of videos, and then they had them do kind of 4 rounds of training. And they were able to improve the median detection by 21% of lesions. And more importantly, they were able to more accurately define where the lesions were. It's kind of like this morning's talk about the skirt on polyps. It's important to know where the edges are, otherwise you'll have residual disease, right? So they actually improved that by as much as 50%. And this was independent based on training and level of experience and what country you were from. So you can't give a talk anymore about GI without having something about AI in it. So what can AI do in patients with Barrett's? I think there's 4 potential areas. This is a nice summary by Pratik Sharma. So you could detect neoplasia. There's high rates of missed neoplasia, so find this missing spot. You could characterize what you're looking at. Is this cancer? Is this a T1B? Is it high grade? You could potentially use it to analyze slides to help sort of reduce the variability of low-grade dysplasia diagnoses among pathologists. And I just told you you're supposed to spend like a minute per centimeter. You could do some sort of a heat map where you say, well, look, you've only looked on this right wall for 12 seconds. You should go back and spend another 48 seconds there before you come out. And you'll know that you've done the full minute for every bit of the surface area. So this is an example of a patient who had an endoscopy. You throw the AI on. It can even give you a heat map, which can help you not only tell you where the lesion is, but exactly how far it extends, so that you can target your biopsy, or like, okay, I'm going to EMR this entire region so that I get the entire thing out. This is a nice video from Jason Sammartino at UC Irvine, which again sort of highlights this. He's done a lot of work in this AI space. Again, you see a cap, high definition scope. Now you're going to see the narrow band. And now you've got this green box, which is telling you, hey, I think there's dysplasia here. And it's giving you a percentage of how likely there is to be dysplasia. It's 80% sure that there's dysplasia there. So I think this is kind of where the future, where we're going to put a box on it, maybe even give us an idea of what level of dysplasia and how confident it is. So these are nice tools that we can use in the future. You can see, again, excellent technique, near focus exam, even underwater with the cap, which helps with the refractive index of water. You can get some really journal quality images here that you can see as you carefully look for the regularity, again, using this narrow band and the Bing criteria. So this is the most recent AI study in Barrett's, which basically trained this computer-aided diagnosis system on a bunch of videos. Then it gave him 30 videos of sort of neoplasia and 60 videos of normal, and then compared them to 44 general endoscopists. And then it sort of ran it against experts and then gave the general endoscopists a chance to use the device. So here's what it looked like. On the left is the red mark saying, hey, there's dysplasia here. The green says it's good. The gray is where the computer says, I'm not sure, okay? And you can see that the computer did great. Sensitivity 93%, specificity 96%. It did better than the 44 general endoscopists on its own. But when the general endoscopists used the device or used this CAT-X, they performed as well as the experts. And so they had 10 experts. I was one of those 10 that had reviewed this. So this is what we want, right? You'd love to have a pair of boxing gloves that you could put on and then you could sort of fight like Mike Tyson or something, right? So this is kind of the way that we hope this works. And so hopefully we'll be able to sort of regenerate this. So in terms of tissue acquisition, again, part of this is visualization, part of it is obtaining tissue. So again, Seattle protocol, 4-quadrant every 2 centimeters. If you're surveilling low grade, it's every 1 centimeter. And we repeat it again, usually every 3 to 5 years or 6 to 12 months with low grade. We know in the United States we don't do this well, about half the time we do it. And the longer the segment, the worse our compliance. So the bigger the haystack, the fewer straws we take, which is exactly the opposite of what we should be doing, right? So this is what the protocol should look like, and I usually make my fellows sort of take a picture when they're done so I can see that there's no areas that are unsampled when we do this, just as a sort of check for quality control. So something you should consider doing as well. So does this really make a difference? For a long time we used to say, oh, there's no study that shows it helps. Well, this study out of the VA suggests that it does. Looking at patients from 2004 to 2009, 30,000 patients, they found that having Barrett surveillance endoscopy was associated with a lower risk of cancer-related death. It actually cut it by about 50%. You can see that on the Kaplan-Meier curve. Patients were diagnosed at an earlier stage, survived longer, had lower cancer-related mortality, and more likely to get an esophagectomy. So it was downstaged. So brushes, in addition to biopsies, may help. This is this sort of wide area transepithelial sampling brush, WATS. It seems to increase detection of Barrett's and dysplasia by 40%. And the concept is, you know, if you take a biopsy, you might just randomly hit these areas, but there's a mosaicism here of dysplasia, and you're more likely to catch that if you take brushings, as you see here. So the data suggests that you can improve your detection of dysplasia by an absolute number of 7.2% compared to a baseline of 16, which means it's about a 50% increase. And that you can basically double your detection of high-grade and esophageal cancer by increase by 2.1 from a baseline of 2.3 on a 7-study meta-analysis. So last couple of points here about predicting future progression and dysplasia to cancer. So the goal isn't where we are right now, but it's to predict where we're going. 90% of patients have Barrett's, with Barrett's esophagus have no dysplasia. So you're trying to predict where these people go. And so we typically use histology. So we know high grade has a 6 to 10% chance per year to go to cancer. So we pretty much always treat that. Low grade meta-analysis suggests at least 1.7% per year. Most people would suggest confirmed low grade gets treated today. But non-dysplastic, the rates are 0.1 to 0.5%, so much lower. And so surveillance is generally recommended. Now, we also know that increasing Barrett's length increases your risk for progression. In fact, it increases the progression to either high-grade or cancer by 28% for every extra centimeter that you have. And if you take a look at this study, in patients who had 3 centimeters or less on the bottom, you can see that their overall risk really was much, much less than people on the top right, who had, it's really a risk that's probably about seven times as much as you increase in length based on 13 centimeters or more or less than 3 centimeters. So this is the progression in Barrett score using male sex, cigarette smoking, Barrett's length, and low-grade dysplasia. And as you can see, if you're a male with low-grade dysplasia, you're already considered basically just about high risk here. So, and the length of Barrett's also counts. But again, nice stratification here. So you can see your risk of developing, progressing to cancer is 12.3% compared to 0.5% in patients who have a low score. So you can see that risk is probably 20 plus times different between those two groups. So finally, we have these biomarkers now that can be utilized. This is a biomarker-based risk stratification that involves 9 biomarkers as well as 7 structural elements. And this is called systems-based pathology. It's also commercially known as TissueCypher. And you get sort of a green score, which is low risk, an orange score, which is intermediate risk, red score, high risk. And this can predict your 5-year progression to developing cancer. So this patient, or to either high grade or cancer, excuse me. So this score was 2.2, which is low risk, and shows that the risk of progression over 5 years is less than 1%. This has been used to show in non-dysplastic patients who score high risk that they actually progress at a higher rate to developing high grade or cancer than even confirmed low grade. So if you're someone that believes that low grade should be treated as a sort of prophylactic technique, then perhaps patients who score high risk on this technology should do the same. This is a study comparing, sort of low-grade, indefinite, and non-dysplastic pathology and their risk for progression in the real-world pathologists. And then they had expert review where you can maybe perhaps select the subset of true low-grade. And that did help. The low grades did progress at a higher rate. But when you use TissueCypher, you can see that you can actually come up with 3 groups. And in fact, the intermediate and high-risk groups here identified 62% of progressors when only 28% could be identified by an expert pathologist. So it perhaps provides us some additional information beyond just histology. So when you compare it to other clinical risk factors in a multivariate analysis among non-dysplastics, the only things that mattered to predict were tissue cipher, higher whole risk or intermediate risk, and a multivariate analysis involving both low-grade, indefinite, and non-dysplastic. Again, those two and the presence of low-grade were the only predictors. So again, another useful sort of adjunct for us. I'll close by talking about endoscopic eradication techniques. This has been something around, and I'll sort of give credit to Dr. Dulé, who, along with Fred Weinstein, was among the pioneers of sort of showing us that you can actually ablate Barrett's and actually get neosquamous conversion, which is sort of shocking, initially with MPEC and laser. But we don't use those as much anymore. But we do use radiofrequency ablation, which is the sort of primary technique, but there are argon plasma coagulation and cryoballoon and liquid spray nitrogen. But before we ablate, we can also resect. This is mucosal resection. And again, this aids in diagnosis and therapy. It's simple to do with a sort of a band and a snare. You can do a cap EMR, or typically more commonly the band ligation technique on the right, which is quite simple to do. This is my partner Ali Sederat's ESD work. He's actually removed almost the entire surface of someone's esophagus there, which he did in about 2.5 hours. So we can remove almost any lesion. This is a lesion he just did 2 weeks ago, which was a T1A cancer that was about 5 centimeters in size, which you can see on the right. So once we're finished resecting, we ablate sort of all the flat sort of tissue that's there. As I said, RF has been done many studies, including New England Journal and JAMA papers. It's effective in getting rid of all Barrett's in 80%, dysplasia 90%. Progression to cancer is reduced. It does recur in 13%, so you do need surveillance, and the stricture rate is around 5%. On the left is cryoballoon, again, small new study, but showing that it seems to have rates of eradication comparable to RFA. Columns 2 and 3 are RFA data, and then on the right are 2 different forms of cryotherapy, one which is not currently available. The spray cryotherapy on the right seems to do well for dysplasia, but doesn't get rid of all the Barrett swell. Cryotherapy does seem to have less pain, but cryoballoon seems to have a somewhat higher stricture rate. So this is a nice technique. It doesn't, I will comment a couple of important points. This doesn't require any capital, really any major capital. It's less than $5,000. It can treat 3 centimeters hemicircumferentially with a single treatment. There's no scraping or double treatments. And this sort of essentially treats 1 millimeter per second. So 30 seconds will treat 3 centimeters. And then this will just drop down, you treat the other side. So it's very efficient. You could treat C9, M9 Barrett's in probably 5 or 6 minutes. So it's actually quite good. And there's a new 360 balloon. APC, we heard about it for being utilized in the gastric fundus. You can treat it for Barrett's as well. Overall pooled results, 91% eradication, 2% stricture rate, 2.7% adverse events. There should be something in your mailbox this week. This is the most recent AGA guideline, which basically just talks about how to do this. They recommend treatment of all patients with high grade, as you would expect, with 3, 6, 12-month follow-up and then annually, and to take surveillance biopsies. They suggest treatment now for low grade, again with surveillance at 1 and 3 years with tissue sampling. They recommend against treatment of non-dysplastic routinely, although they leave the room for selective use. And in patients undergoing EET, they said resecting all visible lesions and ablating preferably with RFA any residual tissue. And then they give some guidance on EMR versus ESD, but suggest that EMR is good for the majority of cases. This is very similar to what we proposed 7 years ago with our quality metrics that were adopted by the ACG and the ASGE. And so in conclusion, modern Barrett's pathway here, I think what you can see here is that if you suspect a patient with Barrett's with the risk factors, you can consider putting them in a risk stratification model or just using one of those cytology devices or doing an endoscopy, manage their GERD and lifestyle, put them in endoscopic surveillance, do a good exam. If they're dysplasia, send them out for endoscopic eradication therapy. If there's no dysplasia, put them in surveillance and go from there. And if they progress on endoscopic eradication therapy, which is rare, they can get an esophagectomy. So in conclusion, improved cell and tissue collection techniques exist. We have risk prediction models and adjunct technologies, and all of these can improve our ability to detect Barrett's and associated neoplasia. We need to pay more attention to training and proper inspection and sampling, specific training, and specifically in focal disease, and perhaps AI will help us achieve this. Risk prediction models, I think, will be important for early intervention in high-risk non-dysplastic patients, and EET is highly effective and durable for treating Barrett's and Barrett's-associated neoplasia. Thank you.
Thank you, Raman. I'm just going to give you a breather in our tradition here. And just a reminder, I'll take this time to say, tomorrow there is a product theater in the morning with breakfast. I think that begins at 7:30. Our regular meeting will begin at 8:40. And I do also want to just remind people to visit the exhibits and talk with the people who give their sponsorship to this meeting and make it possible. And with that, Raman caught his breath. We'll go over some more abstracts from DDW.
Okay, round two. So, all right, so I'm going to talk a little about upper GI motility. I'll focus on some Barrett's abstracts and some sort of general upper abstracts. So one of the hot topics these days is GLP-1 agonists, and do you need to hold them before endoscopy, right? And so everyone's sort of dealing with this. The concept, of course, is that they inhibit postprandial glucagon secretion. It promotes glucose-dependent insulin secretion and mitigating food consumption by delaying gastric emptying. And so that delayed emptying, of course, is concern for retained food in the stomach, perhaps leading to worsening cardiovascular complications during endoscopy, particularly EGD. And so the ASA has recommended that medications be held for a week prior to endoscopic therapy in general. The GI societies have held off on such a strong recommendation. And this study aimed to evaluate the immediate post-endoscopic outcomes in patients using GLP-1 agonists. So it was a cohort study using a claims database looking at a 3-year period between 20 and 22, patients on GLP-1 agonists, and they were matched with patients who were not on GLP-1 agonists according to age, demographics, comorbidities, medications. With one-to-one propensity matching. So they said, we're going to look at what the mortality rate was at 1 week after EGD, and then they looked for other events like acute respiratory failure, aspiration, need for ventilation, cardiorespiratory arrest, coronary syndrome, interventions for coronary disease, and ischemic stroke, and they came up with hazard ratios using a Cox proportion model. So they found a whole bunch of patients. They eventually selected 571 patients who were on GLP-1 agonists and matched those with an equal number who were not. And there was no increase in mortality in the group. In fact, it seemed like the GLP-1 agonists by number-wise had actually a reduction, but it didn't increase it. And there was no difference in acute respiratory failure, shock, aspiration, pneumonia, need for mechanical ventilation. Nobody had acute coronary syndrome or cardiac arrest. And there was actually lower ischemic stroke as well in the GLP-1 agonist group. So at least in terms of the very severe outcomes, they did not see this on a claims database. So now this is another single center study. This is a single center study looking at the same sort of issue out of Cornell, looking at from January 21 to July 23. They excluded patients with malignancy-related gastric outlet obstruction, and they wanted to see sort of how often they saw food in the stomach in patients who are on GLP-1 receptor agonists. And the propensity score matched it with other patients who are not on these medications. Again, very similar approach. So in short, for semaglutide, they actually found that they found food in the stomach, interestingly, in 31%, compared to 9% of controls. Now, I will tell you these numbers are way higher than all the other studies that I've seen. We've actually got 2 abstracts on this exact topic going into ACG tomorrow. This is 3 times what we've reported and what's in the Cleveland Clinic paper that just came out as well. But in any event, it's a 3-fold increase, all right? Then they also looked at sort of the issue of if you got a colonoscopy, did that make things better? And in fact, it did. If you look at the bottom line here, you can see that it actually reduced the sort of food that they found by about 50%, more than 50% actually. Again, semaglutide use, of course, had an odds ratio of 3 for having food found in the stomach, so sort of on this analysis. So they've said that it definitely increases the rates of retained food, but there was some protective effect of doing a same-day colonoscopy in mitigating this issue, and that they needed more studies on outcomes to determine the appropriate fasting protocol prior to these procedures. So there are now a couple of studies I will just mention that suggest that in patients undergoing colonoscopy, preparation who also get an EGD the same day between the 24-hour fasting clear liquid diet and the prep, that they have very low rates of gastric retention. So I think the thing we're all worried about is getting the patient who took their medicine but took a colonoscopy prep, get it canceled. And I think the data suggests that probably we shouldn't cancel those folks. I think we need more data, but that's the early. So another hot topic is these potassium competitive acid blockers. And this is a randomized trial in non-erosive reflux disease. They're felt to be more potent and have prolonged inhibition of gastric acid than PPIs. A small observational study reported that in 26 patients who had PPI-resistant NERD, 70% got better, but 2 randomized controlled trials in Japan did not show a significant difference compared to placebo in terms of a primary endpoint of heartburn-free days. So some question, and a lot of this data has come from Japan. So this was a double-blind randomized trial of US patients with NERD. They had to have symptoms for 6 months before screening, HP negative, no erosive esophagitis or Barrett's. And so they basically got vonoprazan or placebo for 4 weeks, and then the patients who got placebo also then got the medication, and they watched them for 5 months. And you could take some rescue antacids, you kept a diary, you measured your GERD on a 0 to 4 scale. So here's the study flow. You had to kind of this wash-in period, then you basically had your 4-week trial of placebo or one of the 2 doses, and then those on the placebo either got the 10 or the 20, and they watched them for 5 months and saw how they did. This is the first month where they had some had placebo. So you can see the placebo group kind of, you can see this is the percentage of patients who had 24 hours without heartburn. You can see pretty much right on starting, you can see a difference. And you can see the 10 and the 20 are pretty similar, but separate from the placebo there. And that's in fact what you see here is that if you take a look, there's about a 14% absolute difference between the 10 and the 20 compared to placebo with regards to the number of days without heartburn during the day as well as at night. And there's also a statistically significant drop in heartburn severity. Now, when you take now they looked at the end, this is the data from looking at it at the end of 20 weeks. And you can see that some of the patients who got placebo and went to 10, some placebo went to 20, basically it was all the same. So 10 or 20, they all did about the same. 80% had 24-hour heartburn-free days, and you can see the heartburn severity score absolute was actually quite low. So this seemed to do pretty well, at least over around a 6-month period with this. So the strengths, again, is generalizability to a US population. You can see that nearly half the patients were people of color. You can see that, again, it's somewhat limited, though, by the fact that they didn't do formal pH testing, but it was really more based on self-reported symptoms, but that honestly reflects real-world practice. So their conclusions were, it appears to begin as early as the first day of therapy, treatment effect persisted after initial 4-week period through the 20-week extension, and that the 2 doses were equal in efficacy. So the next abstract I wanted to highlight was, can you do a PEG safely on dual antiplatelet therapy? And so this is a population-based propensity match study. You can see that's a popular technique these days. So the ASGE says PEG's a high-risk procedure. You should hold the medicines for 5 to 7 days. The typical antiplatelet medications are the aspirin. Again, ESGE also recommends, again, 7 days holding, and if you're on dual antiplatelets, they usually recommend continuing at least the aspirin. Oops, excuse me. So there is some prior data from a meta-analysis suggesting that it may be safe to do a PEG when you're on both dual antiplatelets, and this study seemed to assess the safety of doing that in dual antiplatelets compared to just aspirin or nothing. And again, this is using that same TriNetX claims database again, which really involves 61 healthcare organizations that cover over 105 million patients. So they basically broke them into 3 groups. Either you had 2, you had 1, or none. So either aspirin, no antiplatelet, or dual antiplatelet. And they looked at gastrostomy-related bleeding at 30 days as a primary. Secondary outcomes were mortality, ICU admission, blood transfusion, or if you needed IR embolization. So this is a busy slide, but basically shows that most of the key parameters are equal between the 3 groups. 90% of these patients were on anticoagulation as well, anticoagulants as well. And so here's the data. You can see that essentially there's no difference between dual antiplatelet and just aspirin in any of the major parameters, and even the same for dual antiplatelet and just nothing. You can see there's really no difference except perhaps for overall mortality, that just a slight edge for dual antiplatelet. So this suggested again that you can probably do this, even when both are needed, which is often the case now with a lot of patients who've had a neurologic injury, and sort of supports the growing literature that this is a safe practice. So I'll transition to a couple of Barrett's related abstracts before I close. So I just talked to you a little bit about how the big challenge is finding patients with Barrett's esophagus. And so this is a study out of the UK that involved that BEST trial that I told you got published in Lancet. And so they looked at some of the data and looked at what are the factors that predicted which patients had Barrett's and what would it take to screen the population in order to maximize finding these patients while minimizing the number of people we actually screened, right? So again, just to briefly summarize, this was a trial that required you to be over 50 on medicines for reflux for at least 6 months. You can't have had an endoscopy in 5 years, and you couldn't have known Barrett's or cancer. And so it put them into 2 groups, standard intervention versus the cytosponge. I told you about the 10-fold increase, and they found more early stage cancers compared to the standard of care group. So what they did find, not a big surprise because I just told you about this, is that male gender and increasing age were associated with an increased risk of having Barrett's or dysplasia. Okay, so that's pretty well known. And they also found that there was a history, if you were a former smoker, you also had a statistically significant increase as well, but not any issues with regards to BMI or alcohol. So they said, okay, well, here's the sort of, sorry, let me go back. Here's the incidence when you sort of look at patients who are men. This is sort of the increasing rise with age for the percent that are women that have Barrett's. So they said, okay, if we looked at 3% strategy to have at least a 3% probability in each of the 2 groups, they said we should start with men at 50 and females at 60. Then they said, okay, let's start doing, what if we needed a 5% threshold, that we have at least a 5% chance of finding it. Then that number increased to 55 and 65. And he said, well, now we want to have a 10% chance of finding Barrett's. For men, you'd have to start at 65. And there's no age at women where you'd hit the 10%, so it sort of said, don't screen women if you're going to do that. Okay, and then they looked at, well, how would this impact the results? So in the UK, they have somewhere in the range of around, 20 million people, I guess, that are in that age group, but about 4 million sort of fall into the group that have the symptomatic reflux. And so when they looked at this, and again, I realize this is sort of a little bit hard to screen, to see here, basically they came up with sort of an answer that the middle group was the sort of best balance between the number of people you could cut off screening but still maintaining it. You end up losing the majority of patients with Barrett's if you screen at the 10% strategy, although you only have to screen about 800,000 people out of that 4 million. If you use the 3%, you end up only losing, probably around 1 million people. But you still maintain the majority of the retention. So they basically said older age and male sex are risk factors for a 5% strategy. They found was the best strategy, 55 and 65 to screen for males and females, which would reduce the screening population by almost half, but still pick up about 3/4 of the Barrett's. So this is a study that talks about irregular Z-line. So I just told you in the last thing, don't biopsy the Z-line. But, Stu Speckler increasingly doesn't believe that that is a good strategy. So the reason we say this is that we know that Barrett's is the only known precursor of esophageal adenocarcinoma, but it requires 1 centimeter of sort of tissue in the tubular esophagus. And again, IM in normal and irregular Z-lines is assumed to have no risk or negligible risk for cancer development. But this is a prior paper that was published by Stu and colleagues, showing that many esophageal cancers may actually arise for intestinal metaplasia in normal and irregular Z-lines. So they found that there was IM in 42% of the biopsies taken from a normal Z-line. And if you take a look at how often they found low-grade and indefinite for dysplasia, it was 7.4 and 2%, which is actually higher than what they found as the prevalence of dysplasia and for indefinite and low-grade in patients who had short-segment Barrett's. So it was actually, if you think short-segment Barrett's has a risk, then it seems that you see the same risk from an irregular Z-line. So they looked at a private group's practice from 2012 to 2018, broke them up into long segment, short segment, and irregular Z-line. and followed those patients and looked, how often they saw either some development of dysplasia in those zones. And they ended up having about 500 short segment, 136 long segment, and 111 irregular Z lines. And clearly long segment had a higher incidence higher prevalence of high-grade dysplasia and a higher total prevalence and incidence for low-grade. What's interesting is that there's no significant difference between short segment Barrett's and an irregular Z line for either finding high-grade at the time of endoscopy, finding low-grade at the time of endoscopy, or developing low-grade over time. So the argument here is then that, you're going to see this, a fair amount of the time. Maybe we should biopsy this area, and this may have more of a neoplastic presence. And it's also interesting because it's also more evenly distributed here among men and women than Barrett's is. It's, here 48% were female. And so even though short segment Barrett's is, not as high of a risk as long segment or an irregular Z line, many more patients have an irregular Z line than long segment Barrett's, and so it may contribute to a greater percentage. And so if we're going to use cell collection devices, they should be sensitive probably for 1 centimeter and even a regular Z line as opposed to just 2 centimeters like I was telling you earlier. So the last abstract I'll do here is tissue systems pathology, which I talked to you about earlier. This is a meta-analysis here, which basically, again, shows that test which has sort of the 9 biomarkers and the 7 sort of structural characteristics. And so this was a meta-analysis looking at several studies on this topic, looking at nearly 700 patients. 185 progressed, 514 didn't. Most of these patients, 83%, had no dysplasia, 17% had indefinite or low grade. And what they found again is that about 5.6% of patients who scored high risk in the non-dysplastic group, or in the whole group, progressed. And if you included patients who were both intermediate and high risk, it was 2.8%, and both of those are higher than what low grade is. And so importantly, it had a 97% negative predictive value. So if you had a low risk, that was very reassuring. And it caught about 60% of all the progressors, in terms of utilizing the study. And these data suggest that it's better than low-grade dysplasia or P53 in terms of its overall assessment. So I think, do I have more time, or do I think I'm up against time, or am I? I think this clock. I'll keep going. One more. This is my last one. I was going to put one bonus in. So this is actually a project that we contributed to, and one of the things that, is that we know that I told you that we can eradicate Barrett's really well, and we can, but we do have to realize that it can recur, and that recurrence rate can be between 1 and 11% per year. So we need to sort of be cognizant of that. So one of the things is, can we predict if you're going to recur and even when you're going to recur? And is there a way that we can use data to kind of create a machine learning model? So this is actually something that was done that we contributed some data to. And so a whole bunch of characteristics were put in. Patient characteristics, Barrett's characteristics, what type of treatment you had, what was your frequency of surveillance, all this sort of stuff. And we looked at what the outcomes were. And so this is from a group of centers, of which, again, we were one, and included a whole bunch of patients from the US RFA registry. Okay, so almost 3,000 patients. You had to get complete eradication, and then we looked at recurrence anytime between 6 months and 5 years. And so you see, when you take a look at this, the overall recurrence was 27%. So you got to recognize this does occur. 10% actually had not just Barrett's recurrence, but actually sort of some form of dysplasia. Okay, and so if you take a look at this, the prediction of Barrett's using this prototype, you can see the area under the curve was actually quite good, 88%, 92% specific, sensitive, and 83% specific. So it's overall pretty darn good. It also could help predict somewhat accurately, a little less so, whether you would develop dysplasia, not just Barrett's recurrence, and the time to prediction area in the curve around 72.72. So we actually created a web-based tool, which hopefully will soon be commercially available for you to look at, where you could just, you're in the office, you punch in a few numbers for your patient, and it'll spit out a number here. It'll give you a heat map in terms of when it likely will reoccur, and you may be able to tailor your post-eradication surveillance based on this data, okay? So, so I think it's an interesting thing. It's a large sample. There was some missing data. It needs to be prospectively validated on a different set. But hopefully, again, trying to give us some information on how we can more intelligently follow our patients. Thank you.